Okay, Mandar, in 1 minute we are going live.
All right.
Yeah. You can go full with your slide.
Yeah.
Yeah. Okay. I can see the view of speaker's view.
Just one second.
Yeah.
That's okay then. All right.
Yeah. So I'm going to start it. Okay, I'm going to start now. So
all right.
one. Welcome everybody to this evening webinar of OrthoTV, and we are glad to welcome Dr. Mandar Agashe. He is a pediatric orthopedic surgeon working in Mumbai at Agashe Pediatric Super Speciality Care Hospital, and he works at many other corporate hospitals and is well known for his academics in pediatric orthopedics. So I welcome Dr. Agashe for his talk on pediatric wrist injury. Over to you, Dr. Agashe.
Thank you, Ashok, and good evening to all of you all around the world. I would like to really thank Ashok for inviting me for this webinar, and also TV for hosting this webinar today. So my topic for today is something which is very common. It's pediatric wrist injuries, which we think of it as very simple, but unfortunately not all are simple, and that is the crux of my lecture today. So in pediatric wrist injuries, I'm going to deal with the things which is most common, that is pediatric distal radius fractures. Why do we have to concern ourselves with pediatric distal radius fractures? Basically because they are the commonest upper limb injuries in childhood. Almost every day we see one child with a distal radius fracture. There are varied injury patterns. They range from simple torus to complex intra-articular fractures. They have varying treatment modalities and they have varying treatment outcomes. So if you look at distal radius fractures in childhood, there are basically 4 types. The commonest being the torus fractures. Secondly, we have the green stick fractures. We have the distal radius metaphyseal fractures. And we have the dreaded Physeal injuries in the distal radius. The first type is the torus fractures. They are the commonest injuries. They are the most benign of all injuries. It's basically related to a buckle in the cortex, and it is because of the thick periosteum which every childhood bone, if every child's bone is enmeshed with. The treatment is whatever you like, which means that whether you give a plaster, a slab, a splint, or just a thread bandage, the fracture almost always heals completely and has an excellent prognosis. Like this child who has healed completely in 1 year. As against that, we have this patient. This is a 7-year-old child, had a fall on outstretched hand and came with this X-ray on day 1. The primary orthopedic surgeon felt that this is a very, very undisplaced fracture, which it was in fact, and gave a plaster on day 1. he asked to follow up after 4 weeks. Is this fine? Is this enough? Well, the child came back after follow up after 4 weeks with this X-ray, which showed that the fracture had displaced even with the plaster on, and you can see that it has led to a ghastly deformity. Why did this happen? Well, one rule of thumb which I usually follow is that I don't usually give a plaster on day one. I usually give a slab, either a below elbow or above elbow, it doesn't matter. I give a plaster slab for pain relief on day one. I call them back after about 3 to 4 days. Once the swelling comes down, then I give them a well molded cast. And there are a few rules for this cast. So what went wrong? Excellent paper written by McQueen et al. In JPO 2012 gives us the risk factors for redisplacement after distal radius fractures. They say that it is isolated radius fractures or complete fractures which are important. Cast index should not be more than 0.8, after which it can lead to redisplacement. I'm going to explain what is cast index. If the initial displacement is more than 50%, then there is a higher chance of redisplacement. If there is less than anatomic close reduction, then there is greater chance of redisplacement. We always feel that an above elbow cast is more secure than as compared to below elbow cast, but literature doesn't say so. They say that it is an equal risk of displacement as if you compare below elbow to above elbow cast. What exactly is this cast index? Well, the cast index is the inner diameter of the cast in the lateral view upon the inner diameter of the cast on the AP view at the level of the fracture. What does that mean? It means that if you have a cast index of about 0.8, it means that the plaster has been given in an oval shape, which is exactly what we want in order to maintain the intraosseous pressure, intraosseous mold. If we give a circular cast, then the cast index becomes more than 0.8, and that itself is not a good cast functionally, and that can lead to high chance of redisplacement. The good thing is this remodeling which is possible in childhood. Will it remodel? Well, there is a great chance of remodeling in distal radius fractures. Less than 8 years, as much as 45%, 45 degrees of angulation can remodel over time. However, you should remember that as the age advances, the amount of angulation which can be accepted is much less. Thus, you have distal radius fractures, green streak fractures. They are not always benign. A well-molded cast is very important. Preferably give a slab on day one and follow up with a well-molded cast after 3 to 4 days. It is important to get serial X-rays, and it is important to maintain the cast index to less than 0.8. The next type of distal radius fracture is this. You have a distal radius metaphyseal fracture. This is a 9-year-old female, had a fresh trauma, comes to you immediately after her fall. What should be done? So on X-ray, we can see that there is a grossly displaced distal radius and ulnar metaphyseal fracture. There is more than 100% translation. What are the options which we have? Can we do a close reduction and a plaster? Can we do assisted or percutaneous close reduction and paper fixation? Should we do an open reduction? And most importantly, can we leave it alone, or can we just give him a plaster without reduction? Now, the most important thing to ask is, can this fracture be left alone? Can we just keep the fracture as is, not reduce it, and give a plaster? Well, there is an excellent article written by Crawford et al., which has come out from Hawaii, about the close treatment of overriding distal radius fracture without reduction in children. So what did they do? The age range was about 3 to 8 years with a distal radius fracture with complete overriding. They just gave a below elbow cast without sedation. They gently molded it to correct angulation. So that is what they did. They did not allow the angulation to happen. So they just corrected the angulation. They did not correct the translation. And what they saw is complete remodeling of the bayonet apposition within 1 year. So this is the X-ray in the article, shows a grossly displaced angulated fracture of the distal radius and ulna. This is the X-ray in the plaster which showed good correction of angulation, but the translation being maintained as is. This is the X-ray at around 6 months, showing complete healing of fracture, but still the remodeling is happening. And at 1 year, you can see that the fracture has completely remodeled. Thus, the question to be asked is that why and when should we actually treat this fracture and reduce these fractures? Age more than 9 years is a definite indication because the amount of remodeling which is possible is much less, especially in females. If the angulation is unable to correct, then you should treat them because angulation is one thing which should not be accepted after a particular degree. If there is severe pain due to median nerve compression, which is possible because of the grossly displaced fragments, then you should treat it. And many a times in Indian scenario especially, the most important thing is this. Because orthopedics being such a visible branch, every person, including this 5-year-old boy, is going to look at the X-ray and he is going to look at the displacement and comment on it. So if we have a elegant way, or if we have a way in which the patient is not harmed and in which you get a good reduction so as not to rely on too much of remodeling, then we should attempt it. So what are these methods? When we look at the distal radius metaphyseal fractures, what we should remember is this. So there is a big mass of pronator quadratus which is interposed in the two fracture sites. How do we treat it? Well, there is an excellent article written by the doyen of pediatric orthopedic trauma, Professor K. Wilkins, who in fact wrote a very succinct line that is, don't throw away the cast. He has described the method of close reduction and giving a plaster in these fractures. How do we do it? Well, basically the deformity has to be over exaggerated. So you hyperdorsiflex the fracture. You hyperdorsiflex almost in 90 degrees, after which you actually run the distal fragment on the proximal fragment till you get a give way, and after which you volar flex the fragment so as to get a good reduction. This is easier said than done, and many a times you are unable to get good reduction in these fractures. So what do we do? Is there any other different way in order to reduce these fractures elegantly without causing more trauma to the child? Well, there is this Kapanji's intrafocal pinning method, an excellent method. I'll just describe you what exactly it means. So if you have a distal radius fracture which is grossly displayed like this, and if you extrapolate this into a diagram, all you have to do is pass a wire from the dorsal surface. It has to be a thick wire. The wire goes onto the dorsal surface of the proximal segment. It is then insinuated into the fracture site. Many a times you have to over-exaggerate the deformity in order for you to pass the wire into the fracture site. The wire is then advanced onto the volar side of the distal fragment, after which it is turned to almost 90 degrees so that the fracture is reduced. So basically you lever out the proximal fragment from underneath the distal fragment with the help of your wire, and then you just advance the K-wire into the proximal segment. You should remember that this wire holds only the proximal segment. It does not have any hold on the distal fragment, and it just sees to it that the distal fragment doesn't go dorsally with the help of this wire. So clinical example. So this is the X-ray where I'm trying to attempt to do the intrafocal pinning. This is one of my earliest cases. You can see that I have used a wire which is too thin, because of which I am unable to lever out the fragment. The wire is bending, but the fragment is not levering. Better sense prevailed, and all I had to do is pass one wire thicker. And once you did that, the fracture was well reduced within 5 seconds. It was well reduced, and all I had to do is advance the wire into the distal, into the proximal fragment, so as to get good reduction. This wire can be kept for a period of about 4 weeks, after which it can be easily removed in the OPD itself. It has been very elegantly described by Sheetal Parekh from Cincinnati as intrafocal pinning for distal radius metaphyseal fractures in children in Orthopedics 2013. You can see the pre-op X-ray here. They have done an intrafocal pinning and have passed the wire into the proximal segment. We can additionally supplement this with one more wire, as has been shown in this method. You can also use this for slightly older fractures, where you can do a callus osteoclasis, as described by Lefebvre et al. In Orthopedics and Trauma 2012. The distal radius metaphyseal fractures can be conserved if there is no angulation. In children younger than 9 years of age, you can attempt close reduction and plastering by exaggeration of the deformity. Intrafocal pinning is an elegant, minimally invasive technique which you should all learn. Preferably don't resort to open reduction, because that itself causes a lot of periosteal stripping, and that has a relatively higher chance of non-union. The last type is this 11-year-old with a distal radius type 2 Physeal injury. Remember, distal radius Physeal injuries are one of the commonest Physeal injuries in the body. In fact, they are second most common after phalanges, and the type 2 injury is the commonest Physeal injury in the distal radius. So in this case, what should be done? Should we do a close reduction, or should we do a K-wire fixation? K-wire fixation, in fact, can be of two types: through the physis or through the thurston organ fragment. But catching hold of that thurston organ fragment is not very simple. This was what was done. A K-wire fixation, a single K-wire fixation of 1.5 millimeter diameter through the physis. When I was doing residency, any wire through the physis was nothing less than blasphemy. But the question to be asked is that, is it safe to pass a K-wire across the distal radius physis? Initially, I used to think no, but there is this excellent paper which has come out from Children's Hospital, Boston, about the effect of pinning across the physis for stabilization of fracture in children. And what they found was very important. They found that pinning with a temporary smooth wire across the physis does not cause physeal growth disturbance. However, they have given a caveat. They have said that multiple field attempts at wire passage and thick wires of more than 2.5 millimeters may be detrimental and should be avoided. So what are the rules of pinning? It should be a smooth wire. It should be in a single attempt. It should not be multiple passes. It should be low torque or with a T-handle. So what I do is I use a T-handle into the epiphyseal segment, look at the reduction, hold it in the reduced position, pass it through the physis with the help of a T-handle itself till I reach the proximal cortex, disengage the T-handle and then put on the drill, and then use the drill only for drilling the proximal cortex. If you want to put two wires, then proceed to it that they cross beyond the physis. And this point is important. That is not too central, not too peripheral. What does that mean? There is a peripheral ring of Lacroix, which is a vascular ring at the periphery of the physis. Now that can be hampered, or that can be irritated or damaged if you pass a wire which is too peripheral in the physis. So the ideal position of the wire is this. That is the junction of the middle to 1/3 and lateral 1/3 of the physis. Always remember, avoid multiple passes. Thus, we should say that it is not the final X-ray which is important, but the intraoperative attempts. Another X-ray of a 6-year-old female with a type 1 Salter-Harris injury. You can see that there is mild displacement, and another plaster was given on day 1. And you can see that after 4 weeks of plaster, you can see that the fracture has got grossly displaced. The Physeal injury has got grossly displaced. Now, should we do anything for this? should remember that there is an excellent remodeling of type 1 and type 2 Physeal injuries and distal radius, which has been described by Hossein et al. In 2004. So you can see that this similar X-ray at 4 weeks almost completely remodels at 6 months and completely remodels at 1 year. So do not retouch a Physeal injury after about 2 weeks or so. What about repeat manipulation and open reduction? Excellently written by Peter Waters and Rockwood and Wilkins. They said that repeat manipulation of a distal radius Physeal injury or forceful open reduction should not be attempted 7 to 10 days after injury due to risk of Physeal damage with growth arrest. Watch for remodeling for as much as 6 to 12 months. After 6 to 12 months, if there is a deformity which is persistent, then a metaphyseal osteotomy will be absolutely effective, easy to do, and with not much of complications. Thus, Physeal injuries do not reduce after 7 to 10 days. What happens is this: there is a growth arrest with ulnar lengthening, which requires ulnar shortening and plating. Thus, distal radius Physeal injuries, remember, they are commonest site after phalanges, of which Salteritis type 2 is the commonest. They have usually good prognosis. Remember that you can cause damage to the physis either because of the injury itself or because of vigorous manipulation or multiple thick K-wire passages. Remember, don't attempt re-reduction after about 7 to 10 days. Just finally, a take-home messages about my lecture today. Pediatric wrist injuries are of 4 types. Torus fractures, you can do anything, you can do slab, masterly inactivity, thread bandage, anything. They are going to have excellent prognosis. Green stick fractures, see to it that you get a good, well-molded cast. Preferably not on the first day, give a slab and then change it to a plaster after 4 days. See to it that you get good serial x-rays every week or so for the first couple of weeks. Distal radius metaphyseal fractures, you should know the method of doing a close reduction by over-exaggerating the deformity. If you are not getting it, you can do an assisted close reduction using Kapanji method. Do not do open reduction of distal radius metaphyseal fractures. Physeal injuries, be gentle. Do a gentle reduction, single shot K-wire fixation, and do not attempt re-reduction after about 7 to 10 days. Thank you so much.
Thank you, Mandar. That was a great presentation there. I think there are a lot of people watching, around more than 350 of them, but not many questions from the audience. Probably they'll pour in next 24 hours. But I have a few questions of mine. So things like you have mentioned serial X-rays. So when do you take these serial X-rays? At what point of time?
What my protocol is that you have to get X-rays in the first 2 weeks of giving a plaster. You get the first X-ray done after a week of your plaster. I call them again after 2 weeks of your plaster. Once the plaster is set and there is no redisplacement at 2 weeks, I don't think that the fracture will redisplace between the 2nd to 4th week. So my protocol is plaster X-ray after the first week, X-ray after the 2nd week, and then directly X-ray after the 4th or 5th week at the time of plaster removal.
Okay. After the plaster removal, what is your protocol for mobilizing them? Or do you send it to a therapist, or you just allow them? Or is there a age or criteria set for doing that?
So my protocol is I almost never send to a physiotherapist because usually they get back, especially in very young kids, they get back the range in no time at all. The most important thing is especially slightly older kids, I ask them to not lift weight or put weight on their limb for about 3 months from injury. So 3 months is the time when I restrict them from lifting of their school bag or something of that sort.
Okay.
I restrict them from sports at least for 3 to 4 months.
Okay.
Because kids are extremely active and playful, and there is a chance of refracture in the first 3 months or so.
Right.
So after 3 months, I just get an X-ray done, and I tell them that you are free to live your whole life
Okay.
without any restrictions.
Right. So for these fractures, Dr. Manoharan is asking, do you give above elbow always or below elbow slab for these injuries?
So I prefer to give an above elbow slab at least,
Okay.
especially my fellowship director used to say that the decision between of giving a below elbow or an above elbow cast depends on how the mom comes in. So if the mom says that he's doing a lot of musty, he's an absolutely playful child, he jumped and did a cartwheel or something, then my preference is more towards giving an above elbow cast.
Right.
As I showed you, literature does not have any preference of below elbow versus above elbow. Both of them have almost equivalent results in terms of risk of redisplacement. But my personal preference is an above elbow cast or a slab and a cast later on.
Okay.
Basically because of the high activity level of these kids.
Okay. So there is another question from Dr. Adam Ali. What is your take on associated ulnar styloid fractures in these cases?
Yeah, in especially in young kids, ulnar styloid fractures are very, very rare.
Right.
Ulnar styloid usually, even if they are there, they will usually heal up. It is very, very rare for me to put a wire through the ulnar styloid, through the ulnar physis. Basically because the ulnar physis does not tolerate a KY through it as well as the radius physis.
Okay.
Basically because the circumference of the ulnar physis is much smaller as compared to the surface area of the ulnar physis is much smaller as compared to the distal radius. So the amount of surface area which is impaled by the wire, the percentage of it is much more as compared to the distal radius. So there is a much higher chance of causing a physeal damage in ulnar styloid and ulnar physeal injuries rather than in distal radius physeal injuries.
Right.
So 99.9% of the time I'll conserve an ulnar styloid fracture in childhood.
Okay. There is another question on how do you tackle brachioradialis muscle pull when you apply the cast?
Yeah, so that's what I showed in the diagram. So
Right.
the most important thing is that the initial action should never be traction. It
Right.
should be hyperextension.
Right.
So once you hyperextend the fracture, what happens is that we hope that the brachioradialis should slip out of the fracture fragments. Once many a time you get a slight click so that you will feel that it has come to length and then you reduce it.
Right.
So you should never just like for unlike other injuries where you first instinct is to give traction, we should never ever give traction in a distal radius metaphyseal injuries initially.
Right.
You should hyperextend, run the distal fragment on the proximal fragment so that the brachioradialis is and then reduce it. I don't think the pronator quadratus is reduced. I don't think the brachioradialis plays as great a role in these fractures as compared to pronator quadratus.
Okay. Okay. There is another question by Dr. Manish Sachdev. He is asking in a 14-year-old patient with Saltairish type 2, grossly displaced lower and radius. What is
Yes.
your option? Close reduction K wire, or any other? 14-year-old.
Yeah. As you told me about grossly displaced. So many a time grossly displaced fractures have high velocity,
Right.
high velocity injuries, and they have significant amount of swelling. Now, most of the time, so a distal radius type 2 injury can be close reduced and given a plaster. But with the presence of so much of swelling, it is difficult to give a well molded cast even after a few days.
Right.
So in this case, it is always better to pass, as I showed you, a single shot K wire through the physis, holding the proximal segment. After which you can, so once the fracture is reduced, many times the swelling also comes down. So you can give a slab for a few days, even extend it to almost a week to 10 days. Once the swelling comes down, then you can convert it to a cast easily because you know that you are secure in your fixation.
Right.
So most of the times my decision of either fixing or just doing a close reduction for a Physeal injury of the distal radius depends on how much of the swelling is there, as well as how much of soft tissue trauma because of the velocity of the injury is there.
Right. Okay.
So I would prefer to put a wire in this case.
Right. Another question by Dr. Alam is asking for distal Physeal Salter Harris type 1 injury after reduction. What is the acceptable angulation for close reduction for type 1?
So type 1 injuries have got a very high chance of remodeling.
Right.
So I will accept almost 30 degrees of angulation, less than about 8 to 9 years of age. Even the thing is, many a times this question is asked not on day one,
Right.
but after a few days when you see some amount of displacement of the fracture.
Right.
At which time I'll accept whatever deformity is there.
Right.
Because I'm not going to manipulate the child after about 7 to 10 days.
Okay.
So after about 7 to 10 days, irrespective of the amount of deformity, I'm not going to remodel. I'm not going to remanipulate it.
Right.
Because we should let the deformity correct itself as much as possible. Right. After which we can easily do a metaphyseal osteo.
Okay.
So on day one, probably about 30 degrees is my cutoff range. Mm-hmm. But after about 10 days, I'm going to accept whatever is left, and I'm going to tell them that I'm going to see you back after about 6 months to reassess how much is the deformity.
Okay. Another question by Dr. Jyoti. She's asking, is there any need for splint after cast removal?
I usually don't give a splint, but sometimes, especially when there is a refracture, or especially as I told you, the child, and I have known that child for a long time, and he is a lot of bundle of mischief kind of person. Yeah. Then it is worthwhile to give a splint for a few months. Right. There's no literature support for giving a splint after cast removal, but I think you should take it case to case. Right. And especially in a refracture case, I'll definitely give them a splint.
Okay. Another question from the forum. What is your take on high metaphyseal fractures? Will you go with K-wires or flexible nail is an option there?
Yeah, so flexible nail is definitely an option there. However, to pass a flexible nail is not very easy, because what happens is that it always goes into a bit of molar angulation. Right. So entry point of the flexible nail is very important. We have a very small segment which is proximal to the distal radius physis, on which you can take an entry. Right. Because even if it's a high metaphyseal, it's a very small segment. Right. So you have to be absolutely accurate in your entry point for the distal radius, and you have to see to it that the fracture doesn't go into volar angulation when passing a tense nail. Okay. You can just put long K wires if required. Many a time, sometimes what happens is that we try to attempt K wires and attempt putting it bicortical, but because the fracture is so proximal or so high, the wires go intramedullary. Okay. In which case, in a way, I don't mind, because as long as there is some amount of splintage internally, I am going to accept that. Because as of now, the best possible means to treat it is doing a close reduction by any means. Right. So if I'm getting an acceptable correction in close means, and even if the wires have gone intramedullary, I'm going to accept that.
Okay. Another question by Dr. Adam Ali. Do you check for TFCC injuries? Are they important in pediatric age group?
To be frank, no. I have, unless it's an adolescent who is a very high performing athlete or something of that sort. Yeah. I have, to be frank, I have not seen a TFCC injury in a distal radius fracture in a child.
Another question by Dr. Sunil is asking, do you bury the K wires or leave them outside?
No, I leave them outside, because I'm going to remove them at around 4 to 6 weeks. Okay. It's a very short duration. Okay. I'm going to just pull them out in the OPD itself.
Right. Another question by Dr. Sudhir. What's your treatment protocol for fracture both bone forearm, distal third in a 4-year-old?
Yeah, so in a 4-year-old, my treatment is almost always going to be just a close reduction and plaster.
Okay.
Unless it's an open injury or a floating elbow or something of that sort.
Right.
In almost always, I'm going to have him with a plaster, a close reduction and a plaster. The acceptability level is going to be very high because I know that at 4 years the chance of remodeling is exceedingly high.
Right.
So I mean 99% of the time it's just going to be a plaster.
Right. Okay. Any specific complications that you want the audience to be aware of, and there are ways to prevent them in this kind of fractures?
In the distal radius Physeal fractures, as I told you, the most important is the Physeal bar.
Right.
Always remember that many a times we get a very good X-ray post-operatively.
Right.
But what has happened in the intra-operative period is the most important.
Right.
The other thing is in distal radius metaphyseal fractures. What I tell the patients that I'm going to attempt close reduction with or without K-bias.
Right.
If I'm not going to get a close reduction by any means, I'm not going to reduce it. I'm going to keep it as it is. In the same way, it's going to be fine. Right. I have a set of X-rays where the remodeling has occurred, and I have explained to them because I don't want to resort to open reduction. Right. We have had a series of patients where open reduction has been done, and this has led to a non-union. So one of the most common, or probably the only reason for having a non-union in a distal radius metaphyseal fracture is you operating on it by doing an open reduction. Right. So the most important thing is do not resort to open reduction in a distal radius metaphyseal fracture.
Okay.
Right? So these are the two things I think we should look at.
Do you regularly counsel the parents regarding the physeal bar in these cases pre-operatively?
Yes. So I always tell them that physeal bar formation is a possibility. Not just so the most common thing which I tell them is that the injury itself is into the growth plate, and that has a high chance of causing a physeal bar, and there is a minor chance of a iatrogenic physeal bar formation. But this is one thing which we always have to look at, and for which we need follow-up, and we have to have follow-up X-rays every 6 months or so in order to look at the growth of the physeals over time.
Okay. So you pre-operatively counsel them?
Yes, always. Every growth plate injury, I always counsel them for physeal bar formation.
Okay, Mandar, I think all the questions are exhausted, and yes. I think you can also give an appeal for Posicon.
Yes. So we are going to have a fantastic Posicon in 2019. All the who's who of pediatric orthopedics in the world are going to come to Mumbai in January 2019. So it is an earnest appeal for all of you to register to Posicon. There will be topics of interest for general orthopedic surgeons as well as pediatric orthopedic surgeons. It is going to be spread over 4 days, and it is going to be really a one-of-a-kind conference. So please do register to Posicon 2019. Thank you.
There are just two questions that came up just now. Yeah. One is the position of the cast that you give. Well, the forearm position, is it in supination, mid-prone, or how is it? How do you decide?
Yeah, so there are a couple of things which are important. One is this concept of the position of plaster is important in green stick injuries.
Right.
Where the position of the apex of the deformity is important.
Right.
So you can have an apex volar deformity or an apex dorsal deformity.
Right.
So if you have an apex volar deformity, it means that it is a supination injury, right, and you require to reduce the fracture in pronation. Right. So once you have reduced the fracture in pronation, you can then hold the entire fracture and then give a plaster in whichever position. So in this case, I give a plaster in mid-prone or neutral position.
Right.
If it's a fracture which is dorsal angulated, it requires reduction in supination, in which case it is very easy to give a plaster in supination. If I have to choose between the position of plaster in supination or pronation, I will prefer supination. Basically because of two things. One is that the interosseous space is maximum in supination. So there is very little chance of you losing range of motion of pronation supination after that.
Right.
The other most important thing is that it is better to have a slight malunion in supination rather than in pronation, because restricted supination is restricted pronation is much worse, much better tolerated than restricted supination.
Right.
Because most of the time, what we do for in pronation, the shoulder also internal rotates. So when we are typing on a keyboard or when we are using the mouse, it's the shoulder which internally rotates much more.
Right.
So it is better to have a malunion in supination rather than a malunion in pronation.
Right. Okay. There is another question by Dr. Sujan. He has a case of 10-year-old child with distal radial metaphyseal fractures. She was treated in a long arm cast, and now after 3 weeks, the fracture is angulated to 30 degrees. What should be the approach now?
How old is the child?
10 years.
Yeah. So at 10 years, 30 degrees angulation is slightly more than what is acceptable. You can attempt an intrafocal wiring at this stage also.
Okay.
Because by literature it is said that you can attempt in 4 weeks a gentle intrafocal wiring and attempting reduction.
Okay.
However, if you are not getting a reduction, do not do vigorous manipulation and do not do open reduction.
Okay.
Allow it to heal, allow it to malunite, and allow it to remodel to as much as possible.
Right.
And once the fracture is settled, it is remodeled, then you can do a metaphyseal osteotomy. Much simpler than doing anything when the fracture is active.
Right.
So I think you can attempt an intrafocal simple wiring, and just attempt reduction. If not, leave it and wait for 6 months or so.
Okay. I think those are all the questions that we have right now, Mandar.
Perfect. Thank you so much, Ashok.
I'm just going to share one of the PosiCon videos, and probably it will be useful. Okay.
Silver Jubilee PosiCon 2019. Hi friends, I'm Dr. Alarica Rogers, and I'm the Scientific Program Chair for Silver Jubilee PosiCon 2019. I'm here to let you know that the abstract submission for PosiCon 2019 is now open. This year, we have 5 categories of abstract submission. 1. A free paper session, which includes the prestigious POSI Best Paper Award. Remember that the top 3 papers win attractive prizes. Second, short oral presentations for innovative techniques and new ideas. Third, video presentations for difficult cases. 4, case presentations of rare or interesting cases, including dilemmas of diagnosis and problems of management. 5, poster presentation, including e-posters. This year, all submissions will only be online
through our website, cosi.in. Remember that only a registered delegate can submit an abstract. However, there is no restriction to the number of abstracts that any delegate can submit. So what are you waiting for? Put in a thinking cap, pull out your laptops, and send in your submissions. Remember, the last date for submission is 31st of July 2018. So hurry.
So that was the announcement. And good night to everybody. Good night, Mandar.
Good night, Ashok. All right. Thanks.
Just a minute, Mandar.
Yeah.